Next speaker is Demetris Taliotis from Bristol, United Kingdom, consultant in Paediatric and Adult Congenital Heart Disease, University Hospitals of Bristol. The title of his lecture is Procedures that can be performed whilst on Ecmo.
Good morning. Thank you for allowing me to participate in this very interesting meeting. I hope you can see my slides. So as you already mentioned, I work at Bristol Children's Hospital, and I'm the director of the cath lab in the children's, also in the adult hospital. And before that, I worked in Glenfield for quite a long period of time, leading the cath lab there. I have nothing to disclose apart from the fact that clearly the lockdown has been very bad for me. Okay, so I'll briefly discuss the setup of the cath lab Ecmo patient, the access, which is of very big importance, the indications and potential complications, as well as outcomes. As the previous speaker has already described, the whole team needs to be assigned to that. There should be local Ecmo guidelines, and all the people in the team need to be involved with this process. The anesthetist in particular, the ICU consultant, if the ECMO circuit is run by the ICU consultant in the particular unit, the surgeons, the perfusionists, the nurses, and the ECMO specialists. Routine checks should be followed as normal throughout the catheter procedure, especially anticoagulation, and there should be an emergency box coming with the patient into the cath lab in case there's a problem with the circuit. There should be spare syringes, ACT cartilages to monitor anticoagulation again, and each member of the team should be assigned to a particular part of the circuit and surveil it very carefully during the procedure. As the previous speaker said, many things can happen during that time. So very important thing is that there should be a slow and steady transfer to the cath lab, and you can see my nurse in the cath lab there navigating the situation with some tennis balls, ping pong balls. The ECMO circuit should be mounted on a mobile cart and move along with the patient very carefully. The patient should be monitored, that goes without saying. There should be sufficient oxygen supply to take you to the cath lab, especially if it's not next door. And the effusion should be carried on as normal. Our local preference is to cannulate femoral artery and vein in over 10 kilograms and neck cannulation in under. And of course, the cardiac patients who have surgery already are centrally cannulated most of the times. Once in the lab, you should brief the team, make sure everybody's role is clear. And the ECMO circuit, most of the time, is set by the table if there's only simple AP view required. If there are multiple views, our preference again is to mount the ECMO and the oxygenator on the table so you can move along with the patient in any direction. The lateral projection use is extremely difficult and I would advise against it. Access is of particular importance since a lot of the complications reported in the literature are due to access. Our personal preference is to use the lines already there. The ECMO circuit can take all the medication that are given through central lines, so that can be done for the period of time the catheter if needed. Sometimes new access is required, and in that case, I would strongly advise that you don't get near the patient unless you have a good vascular ultrasound machine. That will reduce significantly your risk of complications. Use of the arterial cannula can be performed, and that's our preferred option for left heart lesions, and interventions have been performed through the arterial cannula. Avoid venous cannulation, that's my advice. It has been reported in the literature, but the risk of air trapping in the system is significantly high due to the negative pressure in the circulation. So that's how we prefer to access the ECMO circuit. We use a Y connector in the arterial cannula. We set a male-to-male connector, and through that, a Chui-Boss connector. And through that, we put a 4 or 5 French sheath with the appropriate size catheter and shape. We always use a Terumo wire to navigate the bends around the ECMO cannulation until we get to the aorta. As already mentioned, direct injection through the cannula is also appropriate for diagnostic tests, as well as puncture of the tubing, which has been described in case reports. So this is a patient post-Norwoods who was unable to separate for coronary bypass. He was put on ECMO, and an angiogram through the cannula suggested residual arch obstruction, and that was confirmed with a femoral access angiogram and hemodynamics, and the patient went ahead and had revision of the arch. And as I've already mentioned, the Other way to access the cannulation is through the tubing. Very near the cannula, you insert the needle and you put a wire through it with a Seldinger technique. Insert your sheath, do your what you need to do, and then cut that part of the circuit and reconnect. This has been clearly described by Gorensny and Morgan. So what about the indications for the catheter? Well, it could just be a hemodynamic assessment of an unstable child who you didn't have time to assess previously, assessment of a post-operative patient, and that could result to just a diagnostic test, reduced surgery or intervention. I'll talk a little bit about it later. Left heart decompression, planned catheters, and I want to stress that area which is in development, and also ablation of arrhythmias. The biggest center, one of the biggest centers in the world is Boston Children's Hospital, and that's results from an old paper in 2002, which is still very relevant. So the commonest procedure was assessment, followed by left heart decompression. So what about the unstable child who comes in or gets born and there's no time to assess the cardiovascular system? Well, those patients are very difficult to assess post going on Ecmo due to the very low preload and cardiac output. So, and this is an example. This is a young patient who was 7 days of age, brought to Glenfield with the diagnosis of severe RDS needing Ecmo. And a few days later, he's failed to separate from the circuit. So can you see my angiograms? They're not playing for some reason. Playing very slow. Okay, so this patient had hypoplastic pulmonary venous circulation in all lobes. The discussion happened with the parents and the care was withdrawn, unfortunately. So very important. That could not have been picked up by echocardiography alone. What about post-operative patients? When we already talked about the indications of going on ECMO post-operatively, the important thing is that 28 to 30% of these patients will have a residual lesion, which is significant. And echocardiogram, again, is inadequate in this situation because of all the things that are in the way of imaging and the low preload and cardiac output. Only actually, if you look at the literature, only 20 to 40% of these lesions are picked up by echocardiography. In 18% of the cases, in most series, there's a significant change as a result of the catheterization. One very important point is that the timing is crucial. In children on ECMO post-cardiac surgery, if you perform, the literature suggests that if you perform the echo within the first 3 days, the survival is much better than if you leave it for later and then you find a problem. That's decannulation as well as survival to discharge for both groups. So what can you do when you find a problem? Well, about 50% of the residual lesions on the cardiac patients can be dealt with by catheters. Pulmonary artery stenting is relatively common. Fontan fenestration is common, as well as closure of residual lesions, collateral occlusion, angioplasty of the arch or residual stenosis, and septostomy, of course, and atrial stenting. This is an 8-year-old, I hope the videos play, who had the AVST repair followed by mechanical left AV valve replacement. And following that, she failed to come off the bypass machine with a very poor LV function. She was taken straight to the cath lab with ECMO support and was found to have a lesion in the left circumflex, which was presumed to be a fresh clot following the surgery. And that was dealt with by inserting a small coronary balloon and pushing the clot down. We couldn't really, it was a very fresh clot, so we couldn't really push it out of the way. So we ended up having to push the clot down all the way to the distal vessel, and you can see a small lesion in the distal vessel. The child recovered very well with normal cardiac function and went home within 10 days. Another child, another example is a child with post-arterial switch procedure. This child actually did come off bypass and went home, and 48 hours later, he came back with very poor cardiac function, having had good cardiac function before discharge and ST changes. But after ECMO support was instituted, we took it to the lab. We found a lesion in the ostium of the left coronary artery, which was a surgical problem. There was no surgical solution, or thought not to be a good surgical solution due to the size of the patient. So we ended up putting a coronary stent in this patient. And I'm glad to report that she's doing well at 2 years of age with normal cardiac function and good flow down the left coronary. She had redilation since then. Pulmonary artery stenting is very common in many situations, but this is a patient with torsion of the left pulmonary artery after unifocalization. That was dealt with in a straightforward fashion with a stent. There's another example of a patient who had critical arterial flow tract obstruction, has decided to do a BT shunt. At the time, we wouldn't do that now. I would perform an intervention, but it was done, and the shunt occluded soon after. She was supported on Ecmo and then taken to the lab, and the shunt was recanalized. So left-sided compression is another very common procedure that we do on Ecmo. After a while, on a very poor LV and RV function situation, the EDP will go up, and that will cause pulmonary venous hypertension, pulmonary edema, and acute lung damage. So to deal with that, you need to create an atrial communication to decompress the left atrium. This happens in about 20% of patients on Ecmo if they're on a more than 24-hour run. That can happen in two ways. You can do a balloon dilatation, and I would strongly recommend that if that's the choice, it should be done in patients who have short runs on Ecmo, only a few days to a couple of weeks, and you should use a big balloon, 15 to 18 millimeter balloon, even for the smaller children. If the course is expected to be more longer, or the septum, atrial septum is not suitable to balloon dilatation, sometimes there are, then stenting is indicated. And as you can see here in the series of angiograms, stent was done without a TOE. These days we probably do a TOE, but at that time we did it by fluoroscopy alone. What about elective Ecmo? Well, it's a relatively new area of practice. I only came across it in Glenfield, and at that point in time in my career, I learned a lot from that institution, which are excellent in performing Ecmo. And it does depend on local resources and practice. I'm not saying that it should be appropriate for all centers. There is limited published data, mainly in the adults, looking at preemptive Ecmo in TAVI patients and primary PCI patients mainly, versus a rescue Ecmo, and there is a small but significant change in morbidity and mortality. I just described two experiences that I've been involved with. A 34-week, 1.7 kilogram child with severe form of tetralogy fallopian and hypercyanotic spells, was very unstable, ended up going on Ecmo. Well, actually it's bypass, but it could have been Ecmo. And an RV flow tract stent was inserted in the circulation, and the child is now 6 years of age and doing very well. Another patient is a 39-year-old who had truncus repair. He was an Italian chap living in Leicestershire at the time, and he then had an RV to PA conduit replacement and then disappeared for follow-up for 20 years because he didn't like hospitals. When he came into hospital, he was in extremely poor condition, poor RV function with severe stenosis of the homograph with severe calcification, and he was Ecmo cannulated fem-fem electively, had a melody valve implantation with pre-stenting, and then decannulated on the table. As for ablations as consent, I'm not an expert at all, but I would like to say there are two major groups: adults with ventricular arrhythmias, which are not tolerated, and infants with tachymyopathies, secondary to incessant SVTs, which can be very difficult to treat at times. I've added a short case series by my colleagues in Glenfield who performed these procedures at the time for your own interest. So what about complications? Well, our Bristol children's experience is a relatively new experience compared to Glenfield, my previous hospital. I've added it on this presentation. We performed over the last 7 years 19 catheters in 17 patients. They're all cardiac patients mainly. The median age was 1 month. Half of them were diagnostic and the other half were interventions. And we had very few complications, actually. One complication was completely preventable. There was a foot drop secondary to nerve injury for leaving the arterial cannula in ICU and not realizing for 3 days and using it as a central line to give medication. Since then, we altered our practice, and now the practice is to take off all cannulas, all sheaths used for cannulation for the catheter immediately after the either surgical or catheter procedure. There was an LA perforation in a very small child in an attempt to create an atrial communication as well. The survival to discharge was, as recorded in the literature, about 50-60%, and survival to discharge after intervention was even higher. This kind of correlates with the paper from Boston again, which is the biggest series still, even though it was written 18 years ago. which showed that 54 patients were catheterized 60 times. Intervention was done in a significant number of them, and they had very few complications. They only reported 2 myocardial perforations dealt with by drains, and they had a discharge, decannulation and discharge survival of about 50%. They concluded, and I completely agree, that cardiac catheterization can be performed safely on a patient supported by ECMO. And it's actually essential in some situations since it helps with diagnosing residual lesions and can facilitate important therapeutic interventions. So in conclusion, cardiac catheterization on ECMO is safe and effective. Should involve an experienced team, as already mentioned by multiple speakers. Should be performed early in the post-operative patients, and 50% of these lesions can be dealt with interventionally. The complication rate is very low. Elective ECMO is a work in progress, and it's an expanding field. And as we used to say in Glenfield, gradually changing into EABC. ECMO first and then airway and breathing and circulation. Thank you very much.
Thank you very much, Dr. Taliotis, for your outstanding and detailed speech and your marvelous work that you have done. You showed us the need for organized and well-educated ECMO team and maybe the need for reference ECMO centers here in Greece.
I don't think that, I agree. I mean, we have, I don't want to say anything controversial because each different country is different, but we have 2 cardiac ECMO centers in the UK and 1 respiratory center, ECMO center, which is Glenfield, the place I used to work, and that you can tell. When I went to Glenfield, it was a completely different experience for me as far as ECMO is concerned. I could see ECMO used in many different ways I could never imagine. But they are very, very well resourced and very, very well funded. They have 27 nurses just looking after the ECMO program, compared to 2 in Bristol, for example.
Yeah, having said that, though, the difference between the UK and our country here is that you have mobile ECMO. So if a patient, I remember in the very old days, we used to transfer patients on ECMO from the Evelina to Great Ormond Street, where it was the ECMO center. So to have more concentrated experience on ECMO means that you can have collaboration in mobile ECMO. And if you do congenital heart surgery these days, especially neonatal surgery, as we heard, you probably have to have ECMO on site because we have seen that it can save lives, as you showed as well. Thank you for this wonderful talk.